Imagine a literal biological mutiny taking place right inside the human body. We're talking about a scenario where an organ suddenly, violently, and without much warning at all just begins attacking itself. Welcome to this explainer on acute pancreatitis. Today we're breaking down the clinical playbook of a condition that can range from just a mild self-limiting inflammation to a massive, life-threatening crisis involving multi-organ failure. We're going to map out exactly how this enzymatic betrayal happens, how you can spot it, and crucially how to stop it, using the exact clinical data from our sources. Let's dive in.
Here's our clinical triage board for today. We're going to cover the anatomy of the attack, the culprits, spotting the signs, locking down the diagnosis, assessing the severity, and finally, essential management.
All right, Section 1, Anatomy of the Attack, Understanding Autodigestion. Let's set the stage for this biological crime scene. So, the core definition of acute pancreatitis is an acute inflammatory condition caused by the premature activation of pancreatic enzymes. You see, the pancreas has these vital exocrine functions, right? It secretes enzymes like trypsinogen, lipase, and amylase to digest our food. Now, normally, a proenzyme like trypsinogen safely travels down to the intestine before it actually gets activated into trypsin. But in acute pancreatitis, this activation happens way too early, right inside the pancreas itself. The result? Autodigestion. The pancreas essentially starts digesting its own tissue. It's an incredibly dramatic and destructive cascade.
Moving right along, Section 2, the culprits, I get smashed. Let's do a roll call of our primary offenders using that classic medical mnemonic, I get smashed. I stands for idiopathic, meaning, well, there's no identifiable cause. But we really need to put a massive spotlight on G for gallstones, which is actually the most common cause worldwide, and E for ethanol or alcohol abuse. Put together, gallstones and alcohol are absolutely your prime suspects here. Then we have T for trauma, specifically blunt abdominal trauma, which can physically trigger that inflammation.
Continuing down our list of suspects, we find triggers that are medical and infectious. S is for steroids. M stands for mumps and other infections. And yeah, it's wild to think a viral infection like the mumps can unexpectedly spark this entire enzymatic betrayal, but it happens. And A represents autoimmune causes, where the body's own immune system is the underlying instigator.
Finally, let's finish out the mnemonic with the remaining triggers. S is for a scorpion sting, which I know sounds like a random trivia question, but it's a rare and very real trigger. H represents metabolic issues, so things like hyperlipidemia or hypercalcemia. E stands for ERCP, meaning the pancreatitis can actually be a post-endoscopic complication. And D is for drugs. We're talking examples like azathioprine, valproate, thiazides, furosemide, and tetracycline. Honestly, it just goes to show how incredibly diverse the triggers for this biological mutiny can really be. Which brings us to Section 3, Spotting the Signs, Clues at the Bedside. So, when a patient walks through the ER doors complaining of this sudden, severe epigastric pain that radiates straight to the back, and interestingly is relieved by leaning forward, you need to be looking for classical visual clues right on their skin. Look out for the Cullen sign. That's a bluish discoloration right around the belly button, the periumbilical area. Or you might spot the gray Turner sign, which is a really distinctive discoloration along the flanks. Now, I want you to think about this for a second. Why do these distinct, bruise-like skin discolorations actually appear on the patient's belly and sides? Like, what's the underlying pathology causing this massive visual clue? Well, the answer is pretty severe. These signs indicate hemorrhagic pancreatitis. When that premature trypsin activates inside the pancreas, it sets off other enzymes, specifically one called elastase. And elastase destroys blood vessels, leading to massive internal hemorrhage. That bleeding literally seeps through the tissue planes and shows up as bruising on the skin. Missing this sign could absolutely cost a life. It is a major, major red flag.
Okay, Section 4, Locking down the diagnosis, the LAD showdown.
According to the Atlanta classification, you need 2 out of 3 criteria to diagnose acute pancreatitis: typical abdominal pain, imaging suggestive of the condition, or serum enzymes elevated to more than 3 times the normal limit. But in the diagnostic showdown between serum amylase and serum lipase, there is a clear, undeniable winner. While amylase does elevate within hours, it has lower sensitivity, lower specificity, and frankly, a much shorter duration of elevation. Lipase, on the other hand, is your gold standard. It boasts higher sensitivity, higher specificity, and remains elevated for a much longer window.
So if you want to confidently lock down the diagnosis of this crime, serum lipase is for sure your most specific enzyme.
Let's look at Section 5, assessing the severity, separating mild from deadly.
Once you have that diagnosis, there is an immense urgency for risk stratification. We absolutely have to determine if we're dealing with a mild interstitial edematous case, which is reversible and lacks necrosis, or a severe necrotizing pancreatitis, which carries a really high mortality rate due to multi-organ failure and sepsis. To separate the mild from the deadly, we rely on scoring tools like the Ranson criteria. Now, this is a two-part test. At admission, you're looking for red flags like age over 55, elevated white blood cells, high glucose, AST, and LDH. Then, crucially, you have to check again 48 hours later for systemic crashes, like a dropping hematocrit or falling calcium. And that calcium drop actually happens because the fat necrosis binds up the body's calcium. Alternatively, you can use the BISAP score, which is a really quick bedside tool looking at elevated BUN, impaired mental status, systemic inflammatory response, age over 60, and pleural effusion. The rule of thumb here is simple: a higher score equals higher mortality.
Almost done. Section 6, Essential Management, the Emergency Protocol.
Let's walk through the actionable steps required to save the patient and stop this autodigestion in its tracks. Step 1 is fluid resuscitation. I honestly cannot emphasize this aggressively enough. This is the single most important step in initial management, and Ringer lactate is your preferred fluid. Because of the massive fluid sequestration and dehydration going on, you have to support that circulatory system to prevent total cardiovascular collapse. Step 2 is pain control, usually utilizing opioids or NSAIDs, and Step 3 is making the patient NPO, meaning nil per oral or nothing by mouth initially, alongside providing oxygen. You basically want to stop stimulating the pancreas so it stops producing all those destructive enzymes. Now, if that initial attack isn't halted smoothly, downstream complications are going to pop up, and we have to escalate our tactics. If a pancreatic pseudocyst forms and becomes symptomatic, really large or infected, well, it requires drainage. Also, notice that antibiotics are not routinely indicated for acute pancreatitis. They're really only used if there's infected necrosis or sepsis, which might also require a surgical necrosectomy. And if gallstones were the root cause from the very beginning, procedures like ERCP to clear the obstruction, followed by a cholecystectomy after they recover, are pretty much the standard of care.
So we've covered the entire clinical playbook today, from those I get smashed causes to the aggressive fluid resuscitation needed to save a life. But I want to leave you with one final, memorable anatomical aha moment. Why does the sudden, severe pain of acute pancreatitis classically radiate directly into the patient's back? Well, the answer lies in its real estate, the retroperitoneal location of the pancreas. It sits deeply behind the peritoneal cavity, resting right against the back of the abdomen. So when it gets inflamed, you feel it directly in your spine. We know how to manage this mutiny today, but if our own enzymes can cause this much rapid destruction from the inside out, what does that mean for how we might harness or target these exact mechanisms in future therapies? Keep this playbook in mind and never, ever underestimate the power of premature activation.